Right, so as far as I can see, that looks like I'm sharing the right slide. So thank you for the introduction, and thank you everyone to Trauma Care for inviting me back after the conference in February, and then thank you to everyone who has attended this evening or this morning as well. I've seen we've got some from further afield, so thank you everyone. My name is Jake Gluyas-Harris. I'm an emergency medicine doctor and now a registrar as of this week, working in Plymouth, Derriford Hospital in Devon. So I think I've certainly seen at least two people who are nearby, one in Cornwall, one in Devon. So hello to the locals and hello to everyone else. That QR code on there is it should be the open access QR code for the paper. And we've gone with a nice inflammatory title here: Caution Costs Lives, Bolus TXA is safe and saves lives. So I'll pad this out for a little bit longer to make sure I can get as many of you taking a picture of the QR code and improve my citations and downloads, because it's all good for my academic side of things. So yeah. So what am I here today? Why am I talking about this anyway? Why are we talking about bolusing TXA in the context of trauma? Some of you may think this seems like a bit of a null question, or why are we even considering it? Don't we do it anyway? And some of you may have not even considered that this needed to be discussed. So hopefully going through, we'll just highlight exactly where we're going and why we did it. So here's the paper in question that I wrote with one of my consultants in Derriford. And it says there it is based on the Defence Medical Services PGD. So that is the UK's Tri-Services medical arm. Before I put everyone else off, who isn't military, I'm not a military doctor myself, but if anyone's been anywhere near Derriford Hospital, you can't turn around without finding somebody in uniform. So they've made their way in there and they're there to stay. But there's a lot of things here that can be drawn both in the military setup and in the civilian setup. So what we looked at here is why we give TXA how we do, and what harms are we inducing by giving it the way we do, and is there anything we can do about that to maximize the benefit of this drug? And so to begin with, I mean, I sort of alluded to why we're looking at this. So what I want to do first is point out that the whole reason for this is we want to remove barriers and we want to empower people to be able to do the best they can for their patients. And from the start, as I said, some of you may not have even considered, why is this an issue? Why do I even need to discuss about whether I should bolus TXA? And I suspect that those of you who are thinking that, or thinking this seems like a bit of a pointless discussion to have, it's probably not aimed at you. And I don't mean that in a rude way, but the vast majority of people who are administering TXA in the context of trauma are most likely people who do not prescribe. And they are people who are governed by patient group directives, so PGDs within the system they work in, and they're very prescriptive in what they do. Now, PGDs are great because it means that we can identify very set, clear criteria, and we can enable people to give those drugs safely. But it does mean that then they're inflexible. You have to have a specific context, you have to have a specific way of giving it, a reason for giving it, a timing, etc. And while it's okay for someone like me who is a prescriber to go, yeah, I'm just going to give the TXA however I want, of course I am. The vast majority of people given this drug, like I said, do not have that luxury, and therefore they're tied into doing what people like my seniors do and dictate the rules and the regulations around this to give it that way. And as we'll go into in a little bit, why that might be a problem there and why we need to move with the times and change things. So to begin with, I just want to go through a brief whistle-stop tour of the evolution of TXA. Discovered in the 1970s in Japan. Mostly then it was applied to surgery as a prophylaxis more so, or management of bleeding or minimizing bleeding, and particularly in cardiothoracic surgery. So a lot of the early data was around cardiothoracic surgery, around cardiac surgery, and with that, the type of patients who have the comorbidities that go with having cardiac disease, and particularly coronary artery disease. floats around for sort of 30, 40 years. And then in 2012, there's a paper published called the MATTERS trial, which is the military application of tranexamic acid in trauma emergency resuscitation, I think, something to that effect. And what that was a retrospective look at all the data collected in Afghanistan over a period of time for injured service personnel and civilians that were treated in Afghanistan who received trauma resuscitation. And they looked at those who received TXA and those who did not. And this is where we got this first sort of published data that actually tranexamic acid was pretty good in trauma and that it saved lives in trauma. And importantly, just highlight there, it saved lives even if you received blood, even if you received a lot of blood, you did better if you had TXA. Even if you were critically unwell and therefore were receiving a massive transfusion because you were dying from blood loss, you did better with TXA. Now, in this one, there was a little bit about increased risk of venous thromboembolisms. They were giving larger doses than we give now, but that set the scene of actually, here's this new drug that might be able to save people's lives. The year later, in 2013, CRASH 2 was published. I assume the vast majority of people here have heard of CRASH 2, but if they've not, it's probably one of, if not the biggest trial in acute care. 20,000 patients enrolled across a mix of sort of Western trauma settings and low and middle income settings. And that was a case of anyone who has a traumatic injury and has evidence of blood loss, or at least has indication they are bleeding, is given tranexamic acid. And the headline from that was TXA reduces mortality by 1.5% if it's given within 3 hours. That was the headline. It's like, wow, 1.5% doesn't sound great, but you know, in modern medicine, we're looking at the small percentage points, so you kind of need to go, actually 1.5% is pretty good. And that's an absolute risk reduction. And here's the bit we sort of get to there is that was given as the way they gave it there was 1 gram initially and 1 gram later on. And the first gram was given over 10 minutes. And for those who don't drop drugs or aren't familiar with it, TXA is 1 gram is 10 mils. So that was 10 mils, 1 mil a minute. That was your first infusion. And we stuck with that. And I'll explain sort of where that came from in a minute, but we've stuck with that pretty much since that came out. That's what we did. That's what we had the evidence for. So we go with that. A couple of years later, the woman trial done by the same group who did the CRASH 2 trial, similar thing, but it was in postpartum hemorrhage and for women giving birth. And they used a bit of a slightly different thing because thankfully it's a pretty rare complication to die there, which is a relief. But they did a composite of hysterectomy and death. And again, we saw a pretty similar thing that we saw in CRASH 2. TXA, you do better with it, low risk of both of those things. Now, come 2018, and this is where sort of the evidence that we've been building on has come from. There was a meta-analysis of those 2 data sets. And I don't know if I said women was the same size, 20,000 patients. So you've got 40,000 patients given tranexamic acid to try and prevent bleeding and death from bleeding. And actually, when they looked at things, this whole thing of give it within 3 hours, that's true. But actually, they found that it wasn't really just give it within 3 hours and sort of kind of intuitively, it was the earlier you give, the better. And for every 15 minutes after you give it, you're losing about 10% of that benefit we've seen. So while we know the absolute number is about 1.5%, if we can get in earlier, we may bet we're better than that. We can do more. It can be more beneficial. There was a caveat to that within the first hour, they didn't see so much difference. And one of their reasons they think is actually, unfortunately, the patients who got it within the first hour, there was a large number that were going to die anyway. And they think that may have skewed the numbers. But certainly from that first hour onwards, earlier was better. And so now we've gone from it helps and it improves the outcomes to give it within 3 hours and it improves the outcomes to actually get in as soon as you can and you're going to get the best benefit from it. And then in 2023, the most recent sort of large data set piece was something called patch trauma. And that was similar to CRASH 2, but it was done in well-developed Western settings. So Germany, Australasia, because there's some comments that actually CRASH 2 wasn't applicable outside of, or it wasn't applicable in big, well-developed, well-established trauma systems like the UK, the US, Australia, Germany. But actually, patch trauma showed the same thing. They were looking at neurological outcomes, which is not really the topic we'll discuss here, but I'm sure there's going to be some questions that will come in about that. But in terms of mortality benefit, we saw the same thing in patch. And so then the next thing we get onto is that 10-minute infusion bit. So why was that done? So if we look at the summary of product characteristics, which is where this sort of comes from, that's your piece of literature that the pharmaceutical company that owns the drug produces, and it tells you what it's for, why it does that, and most importantly in this case, how you give it. And you can see there we've got the 10 mils or 2 5 mil ampoules of TXA by slow intravenous injection at 1 mil a minute. And then you can give the second doses given over 8 hours thereafter, which is how we do it. And that's stuck. And the reason they've gone for this slow dose is there is concern that, as I've highlighted there, that there is a risk of hypotension, and there is also some concern about seizures as well. And those are particularly there, the hypotensive episodes was particularly about too fast an intravenous injection. And so when David McConnell and I were chatting about this, we came to this point and went, okay, we now know that TXA is actually not just a case of within 3 hours, but TXA is the sooner the better. We've got this number of about 15 minutes is about a 10% loss of benefit. But then we've also got something that explicitly tells us we have to give this over 10 minutes. And that's where we went, actually, we're missing a trick here. Why are we doing that? Why are we introducing some risk there to the patients when actually we could be giving it sooner, we could be giving it faster potentially, and we could be getting more benefit from this drug, which is pretty, in terms of risk benefit, there's no increase in VT risk when you're using it at the doses we are. And this is the only proposed complication, that you might get a bit hypotensive and you might have a seizure. But we said, actually, where's the data for that? Where's the evidence for that? And I should mention why it was kept in, really, in the crash data, because they've seen this and they understand this, and having had some communication with Ian Robinson, Professor Ian Robinson, who ran this trial, he's aware of that. And the reason they kept it in the first place was they didn't want to confound the results. And so what I mean by that is, if you have, in the setting of the trauma patient who you think is bleeding, one of the things we look for to go, actually, is this person bleeding, is if they become hypotensive. And in fact, JR Calc's guidelines and lots of the other guidelines like that, that is the thing you look for, is like, have you had a traumatic injury? Are you hypotensive and tachycardic? Oh, you're probably bleeding. That's, from getting as the bare minimum information you can from the patient early doors, that's what you're looking for. And so the concern from the crash team was, if I give you a drug that potentially makes you hypotensive, and I'm trying to distinguish whether or not I need to give you blood based on one of the parameters that is you being hypotensive, I might end up skewing all my results simply because in the study arm where I gave the active drug rather than the placebo, I'm making people bleed more, or not making people bleed more, but I'm making it appear as though people are bleeding more. And then if they appear as though they're bleeding more, they're more likely to get other interventions like receiving blood, receiving calcium, other things we do when we're resuscitating people who are bleeding. And that in turn may skew the results, particularly in this setting, because we know, blood is not benign. It comes with its risks of coagulopathy, making people more likely to bleed if you're giving them blood resuscitation. And if you're giving a drug that you're trying to minimize blood loss and you're giving them something that might promote it, you may just completely ruin all of your findings because you're inadvertently confounding it that way. So that's why Prof. Roberts and his team kept it in. They said, look, this is what it's purported to do. We don't want to ruin our results. We want to see how good TXA is. We don't want to skew anything and get the wrong data. So that's why it stayed in there. And so we came in, as I said, with this new data that sooner is better. And actually, all these things add delays. And so we wanted to go, actually, how can we square this away? How can we improve the care for patients? And particularly, how can we improve the PGD so that those who are given this drug under our sort of nominated responsibility can do the best for patients? And we looked at this two ways. And we said, we can probably quite easily look at the benefit of giving it as a bolus and giving it faster, getting it in earlier and not delaying anything. And we could almost say, actually, it doesn't really matter about anything else because the benefit is so massive, it outweighs any risk. But we said, actually, no, we do need to review the evidence for the risk of harm. We do need to look at that side of things. Some people have taken a sort of slightly different approach and just looked at the benefit of the bolus, but we said, actually, let's look at both sides of things. And so as I said, benefit of the bolus, that's it, pretty much there and then. The benefit of giving it 40,000 patients, bleeding patients, Sooner is better, not just within 3 hours, but actually every 15 minutes you do, you're losing benefit. And just to try and quantify that sort of loss, 10-minute infusion. But it's not just 10-minute infusion, because you've got to get IV access, which, as we all know, can take 10 seconds to 10 hours. Not only have you got to get IV access, but then you've got to get your pump ready, prepare your pump, draw up your drugs, and get it in the right syringe ready. You've got to program your pump. Your pump's going to be plugged in. Your pump's going to then alarm because the pressure's too high. There's an occlusion because they're bending their arm because they're in pain. And then you've got to try and move them with a pump attached with a spaghetti wire going somewhere that's going to snag around something. And meanwhile, you're in an austere environment. Now, is that an austere environment where you're getting shot at because you're on deployment? Or is that an austere environment because you're on the A38 on a day like today when it's pretty grey and grisly and grim outside, and you've just had two people total their cars into each other, and actually the last thing on your mind is sitting out there with this patient getting cold, they're hypotensive, you just want to scoop up and get them out of there. So anything that is going to add to your on-scene time, you bin it. And that was our concern there, that actually if we kept with this really rigid PGD, people are going to lose the benefit of the bolus, because they'd say, actually, the safest thing for me to do is get this person out of here. And so this is the benefit of the bolus. And that's just, assuming that it was perfect, slick, bam, 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 needle in, straight away, canyon off. It's already set up, we're going. 10 minutes, that's already losing you some benefit at the very minimum, potentially, just the time of using it. And so when I said that some people have just gone with this sort of, the bolus is beneficial, hang the rest of it, I want to steal this term somebody's going to have to try and remember who it was, but there was a gentleman who spoke from the armed response unit of the Met Police when we went to the trauma care conference. And I've stolen his phrase here completely. So if anyone knows his name and would like to credit him, please do. But it was talk of operational pragmatism. And, as I said, there's a couple of trials there, but the MATTERS trial, the military application of TXA trauma, and then there's a few more that have been adopted by other military forces around the world. So the 75th Ranger Regiment they've decided that actually they're just going to go with 2 grams straight up and they're going to flush it in. And the Israeli Defense Force have also done something similar. Interestingly, the Israelis they did it quite a lot before any of this stuff came out, and they did it over a 5-minute infusion. So they were clearly going, well, we want to get it in, but we're going to hedge our bets because, we still got to do it slowly. But both of those, and actually the TCCC, which is the Tactical Committee on Combat Casualty Care, I believe, which is one of the American groups that oversees all of this, they've just said, don't care, 2 grams straight away, none of this 1 gram over 10 minutes, just give them 2 grams straight away, get it in. And on that note, anecdotally as well, there's other places in the UK doing this. So I think London, if anyone's in the audience and can confirm that, because I couldn't find any external evidence, London have said, yep, 2 grams straight away as a push, that's getting it in, we need it in. At Trauma Care, I met a Polish paramedic who said that they've done exactly that. Part of theirs was problems with, did it go in pre-hospitally? Did it not? Have they had 1 gram? Have they had 2 grams? They just said, from a pragmatic point, they went, just give them 2 pre-hospitally, standard procedure. We know they've got it when they arrive in hospital. We know you've done your job. And he said that they've gone with that. And again, anecdotally, they've not had any concerns or issues with this there. And interestingly, when we circle around to it, the MATTERS trial, even if you were hypotensive, even if you're receiving a massive blood transfusion, you did better if you had TXA than without it. So again, with this sort of the hat of operational pragmatism, even if it made you a bit hypotensive, it's going to be better for you, is sort of that standpoint. So just there is the benefit, is the bolus beneficial? Probably. And we could probably do without that. But then we wanted to go on and say, actually, where's the risk of harm? And so we trawled through the references and where the summary product characteristics had come from and tried to find the evidence that they quoted. And we couldn't find it. We couldn't find where this data was that said there's a risk when giving it as a bolus. I couldn't find any publications on it. And then we went to the interactive drug analysis profile, sort of anyone who's familiar with giving drugs at all, which I imagine is a lot of us here, if not everyone, the yellow card system the MHRA has in the UK. So that's our Medicines Healthcare Regulatory Authority in the UK. Any adverse event or reaction or anything to or suspected adverse event to any drug that's administered in the UK must be reported via this scheme. And so we had a look at that to see actually, are there lots of reports coming in that we've just missed or that we've ignored? And there were a total of about 1,500 reactions. Adverse drug reactions, about half of those. Serious adverse drug reactions, 500 odd, with 30 being quoted as fatal reports. And then within that breakdown of all the adverse reactions, there were 5 episodes of hypotension, there were no fatalities, and there were no seizures recorded. Now, that's great. Obviously, it's only not even half an answer. We don't know what the bottom figure is. We don't know what the denominator is of all these things that are given. But if it was that serious, you would hope that it would get reported. And it's not perfect data, but it's the best we can go with. Now, I've asterisked the no seizures there because there is another trial that at the time of writing, or just before we published this, actually, the new NICE head injury guidelines came out. And for anyone who's not familiar, in the UK, the NICE guidelines have recommended in isolated traumatic head injury, where there's no concern of bleeding with a reduced GCS less than 12, they have advocated giving a 2-gram bolus as a push straight away. And in some of the data they used there was a hint towards increasing risk of seizures in that 2-gram bolus group, but it wasn't significant. So that's why I just put no seizures there, because in the interactive drug analysis profile, that's the truth. But some stuff floating around that might otherwise say otherwise. And so this was what we could find as our evidence for risk of harm. So in the 1,500 reports, we had 5 episodes of hypotension, none of which were fatal. So again, going back to sort of operational pragmatism, if it made you a bit hypotensive, is that the end of the world? Depends where you come from the point of view, head injury, traumatic brain injury, all those things in there. But as we said, we know that giving it even in the context of hypotension is beneficial. So, I know where I stand on it. I'm obviously slightly biased, so I'll let everyone else make their own decisions based on that. And so here's our, this is basically the output we had and where we went with it. And I don't know if my video is covering up half the screen there, whereas it was covering the QR code. So I've just shot myself in the foot there. But the risks of giving a bolus, hypotension, as I've just been through, no fatal episodes, tiny numbers of reported ones, and actually it's probably still beneficial even if you're hypotensive already. Seizures, some low quality data indicating that sort of hinting towards an increased seizure frequency, but not statistically significant. Obviously, you can read into that as you will. And that wasn't seen with giving 1 gram. Most importantly, that was only when it was given a 2 gram. There's also some concern that actually, if we deviate from the crash tube protocol, which is a great study, it has its flaws as everything does, but it's a solid study. We know what it did. But if we go away from what they did there, can we honestly say that we're going to get the same benefit? And actually, there are some papers, some pieces that you can read in the paper that do look at that, do look at the pharmacokinetics, and it says, actually, yeah, giving it as a bolus, you still see the same modeling, you still see the same therapeutic levels in a bolus as you would do. Now, the benefits of giving as a bolus: compliance. So anything that minimizes on-scene time, anything that promotes giving it as early as possible to point of wounding or point of injury is going to be beneficial. The efficacy, as we've sort of banged on, and you're probably all fed up of hearing by now, the sooner the better. And anything that's going to minimize keeping us on scene, because understandably, you're going to defer anything you have to get someone to a place of safety. And so that's where we went. So we sort of came up with, this is the output, this is the headlines really. And we came down firmly on the side of a bolus is safe and a bolus saves lives. And really, we should be pushing for the PGD for TXA to be given in traumatic injury with risk of bleeding should be given as a bolus. And equally, I'd like to try and, I think, personally, it'd be nice to go and take this to JRCALC, who's our ambulance service governing body and guidelines, and put it on board with them as well, would be where I'd like to see this going. What next? So you could say, do we need to do a randomized controlled trial looking at bolus versus infusion dosing? I think probably not. Do you need to collect some data on it if you're doing it anyway? Possibly, and obviously that would be useful, but it's limited in that it's only sort of going to be a retrospective type thing. But actually, I think the future of this is IM injection. and particularly TXA auto-injectors. And this is not a new idea. This has been something that the UK military medical services have put out for procurement several years ago now, and people are still trying to do it. The main issue being the volume. So adrenaline auto-injectors, wonderful. And as long as you can work out which the pointy end is and which the blunt end is and not fire a load of adrenaline into your thumb, they're pretty foolproof. However, that's a tiny volume, tiny volume. They've had real difficulty getting TXA down and suspending it in something where they can concentrate it enough. So that's a problem. It's also not a sexy drug from the perspective of the pharmaceutical industry. I'm not or nasty big pharma. Pharmaceutical industry is wonderful, does a huge amount of good for us, but their bottom line does come down to sales. And if you have a drug that is very old and is off patent, there's not so much incentive to work on it and do things there. There obviously is procurement. As I said, there's a big procurement contract out for someone who can make this. And as of the time of writing, there's this device there from the US. I'd have a look at it, the Mac 32. And we're talking sort of not even 1990s, but 1980s, beginning of the mobile telephone, huge things. And even in some cases, they've gone with having two, so one in each leg. Obviously, this would be great. So not only from the military perspective, you can give yourself they carry in their own analgesia should they need it. You can give yourself a tourniquet. You can give yourself a TXA injector. You can buddy up. You can do your own. It's a great idea, and it removes a lot of those logistic barriers of what is going to keep us on site. If you can just bosh it straight in with an auto injector, it's done without even thinking about it at the point of wounding. Wonderful, it's straight in there. There are some studies that have been looking into IM dosing, again with Prof. Roberts and some of his colleagues, and actually the early indication looks like it's probably as good. It maintains therapeutic levels. No one's yet done it as a IM as your first dose. They did the IV dose and then the IM, but it all looks pretty promising. And I think this is where we're going, because particularly if you're thinking low and middle income countries where people who are administering this at the point of injury are not necessarily qualified to gain IV access or carry drugs in this way, but if they can give it IM, stick it in a leg or in a shoulder, easy. And also from the perspective of not just trauma, but childbirth in places where not everyone is managed in hospital, or not everyone who's at risk is in hospital. And even those who aren't at risk and suddenly start bleeding, if you can just put it straight into someone's leg, it minimizes all these hurdles. And I think this is the future. I think this is where we're going with TXA. And I think in a couple of years' time, I wouldn't be surprised if we're seeing an IM TXA RTC. And that's me done. That's a whirlwind through what we did, why we did it. And my whole thing here was, I want to show you where we've come to and why we've come to this, because it's all very well and good if people such as my senior colleagues go, we'll change your PGD and this is what we're doing, and you're just going to bosh it in. And you go, hold on, but why? So I didn't just want to be the person who goes, this is how it should be and impose it. I want to show you why we've done it and actually why we want to change it. And as I said at the beginning, it is that. It's about removing barriers and empowering those who are acting on our behalf to do the best they can for these patients by making the PGDs that they have flexible enough, or rather safe enough, to maximize the benefit. And that's me done. I'm not sure my timing, but about half an hour in, I think that's me.
Stunning timing, and I do apologise everyone, because now you are going to watch me in the dark for reasons I've already explained, but you can see my face just about. It's just a bit of a horror movie now. So thank you very much, Jake, for that, for the whirlwind tour that was, but very useful information did come out of it. So I've just rearranged my slides some just so I can go back to this slide, because it is a slightly important slide, which I did skip past in my flurry before. So now you've watched that and you can see the content that we provide. If you enjoyed it, you want to find out more, you want to watch more similar webinars, I would highly recommend scanning the QR code that's on your screen now and becoming a member. It starts from literally £3 a month for non-registered healthcare professionals. That is those of you who aren't registered to any governing body. Students, which name is on the tin, and full members, which are those of you who are registered to governing bodies. If you scan the QR code that's on your screen, not only do you get access to our entire back catalogue of webinars, If you solely rely on our YouTube channel, you're probably noticing recently that more and more videos have been coming off. They're not maybe relevant anymore. They're not racking up views or anything like that. But we're trying to make it that the members get more bang for the buck, essentially. So we're making a lot more of our webinars member exclusive. After obviously all of our webinars will remain free to watch live, but yes, and this webinar will be going on YouTube, but we're going on for a limited time, sort of between 1 to 3 months. But if you want more webinars like this one and free CPD certificates, 10% discount in the shop, discount on early bird tickets. So if you already are buying an early bird ticket, if you remember, you'll get a further discount on top of that, as well as discounts continued across all of our ticketed events as well. And there's many more perks to becoming a member and stuff that we are continuously working on to improve your experience. So if you enjoyed that, do scan the QR code that's on your screen now and consider joining us as a member. It is the memberships that keep us ticking over as a charity as well. So you are all highly, highly valued people within our community. And the next webinar coming up on September the 12th. So after we've been to Ireland, I'm giving myself a little bit of a break from webinars just so I can focus solely on Ireland for the next couple of weeks. However, we will be joined by Major Matt Ellington to talk to us on dried plasma and the future of blood far forward. Since the talk took place, again, another rehashed conference talk that we're doing to bring updates, allow Matt to talk for a little bit longer than maybe what he got at the conference as well. So he's joining us on September the 12th at 8 o'clock. Do scan the QR code that's on your screen now, and you can join us then for Matt's talk. And the important part, if you're not a member, this is your chance to scan the QR code that's on your screen now and purchase your CPD certificate for just £1.99. However, as I've just mentioned, becoming a member is only £3. It's only £1 more, and you'll get double the amount of certificates in a month, and you'll get them for free for life. When you purchase a certificate from us, it gets dropped into an online portfolio that we work with called Accredible, and that certificate will only be available on that online portfolio system for 28 days. And on that portfolio as well, you can upload your evidence, keep all your certificates together. It's a great little system, but non-members only have access to it for 28 days. If you're a member, don't worry, it will be dropped there tomorrow and you'll be able to access it for life. Q&As. This is your chance to ask questions. We've already had one come in from Gary Sinclair. Thank you very much, Gary. Here's asked Jake, you have said that you see the future being IM delivery. Does that lead to TXA being less efficient as it is going to act slower than being given the bolus via IV?
So that's the question, isn't it?
Yes.
So that's possibly the case. However, we don't really have enough data to say otherwise. We don't have enough data to say whether it will be slower, but the early data, which is only about 23 patients, is a paper by Ian Roberts about IM TXA in bleeding trauma patients. I'd have a look at it. So the early ones suggest that actually it probably does do just as well, and you can get therapeutic levels with IM dosing. And their paper suggested that you can maintain appropriate therapeutic levels in a bleeding trauma patient. So these were shocked patients who were hypertensive, had evidence of bleeding, and were blood resuscitated. They received their second dose as IM, and actually through the actual plasma levels they took, and they showed you were still maintaining it at a therapeutic level, the same as seen if you were giving 2 IV doses. So it's suggesting that actually it is safe and it is going to replicate it, and you are going to get the same therapeutic levels, but whether that is borne out in the initial dose that is given remains to be seen. And that's really why we need to get some data, and as I said, probably need to have a randomized controlled trial that looks at giving IM dosing. As you say, without enough evidence to say otherwise, it's tricky to start justifying that and going, well, we know that IV is really good, so why would we not? But watch this space. Someone cleverer than I is going to come up with a proof that it works, and then the proof will be in the pudding when we get a study, or won't. That's why we do them. But yeah, it's certainly a concern, but I think the evidence is pointing towards it probably is okay so far.
Perfect, thank you. Someone asked very simply, Anita Cawley's asked, Jake, will this be implemented at Derriford?
If I get my way, maybe, and certainly I've already been bolusing people as soon as they get in, so I think it depends who you're on with. But the difficulty with this again is TXA is not a hospital drug. TXA is a pre-hospital drug, And that's why this is even more important that, you know, if we can get to JR Calc and we can say to them, actually, you need to get this in as a bolus, not as a 10-minute infusion, because most patients should ideally have received their first dose already. And if they haven't, we're already behind the curve. So yes, I would like to say it will come in Derriford. And when I'm on, it certainly does, but it needs to come before Derriford. It needs to come before they get to hospital, which is why it's so important that we do stuff like this, and we can start talking to our ambulance colleagues.
Amazing. Callum Dawson's asked, just regarding the wording to the PGD, if you're familiar, not to be used in GI bleeding. However, I would assume in trauma, even abdominal, you would still be giving TXA because of the assumed involvement of the Why do you always give me words I don't know about? Vasculature.
Yes, so this is, again, if I'm telling people what they already know, this is talking about Crash 3. So Crash 3 was the trial they did, not Crash 3, Halt It. So Crash 3 was head, Halt It was the trial they did looking at GI bleeding in TXA. And the headline there was, actually, it doesn't do any good, and it doesn't improve mortality. But there's a couple of issues with that paper, which it's probably not time to go into, but around timing. But yes, so if somebody has been traumatically injured, it's a different mechanism and it's a different pathology you're dealing there, rather than an acute GI bleed, be it from a big ulcer or from someone's varices from their liver disease, that is specific points within that GI system. It's traumatic, something's bled, lots of bleeding surfaces, whatever. So yeah, that's the caution of using a GI bleed. But if someone's been hit with something, or they've jumped off something, or fallen off, or whatever, yeah, you treat it as trauma, not as wherever the bleed might be from.
Perfect, thank you. An anonymous attendees asked, oral bioavailability is up to 50%. Would you recommend this route if others are not available?
Yeah, if that's the only option you've got, although you can always get an IO needle in if you need to. It is pretty good bioavailability, and certainly, again, out of Derriford, the British Antarctic Survey medical unit, that is their standpoint, that if they can't get access to somebody, which will be tricky if you're in Antarctica, they will give it orally. So yeah, so it's get it in however you can. It's all going to come down to what you're carrying as well. And again, that's why IM sounds great, because it's really hard to get that wrong. And even if you get it wrong, you got it IV, and we know IV works. So yeah, all for the IM. But actually, if you look at the JR Calc and other guidelines, it says IV, and it already has in there, or IM if not possible. So IM's already written into most of the guidelines, suggesting that it is the backup plan.
Amazing, thank you very much. I'm just going to go through the, keep this on the screen for a couple more seconds so people have a chance to scan or take a photo and, and go on. That does seem to be the last of the questions that have come in. However, I always say that, and more questions start coming in. So once I go through the sponsors, everyone, because we do have a little bit of time left, I'll just let the questions stay open. If anything else comes in, as I'm thanking our sponsors and yourselves, we'll jump back to them, but we shall see. So, of course, first of all, thank you. Oh, straight away, I said that. Why can't it be given IO?
It can.
There we go.
It can be given IO, absolutely. And again, that's the standpoint. You know, can I get a line in? Can I get an IV line in? Yes, no, right. I can't get an IV line in. IO it is. In trauma resuscitation, IO is not great, just because of, if somebody is getting TXA, you think they're bleeding, and you need something you can give volume faster. But yeah, if that's what you've got, get it in. But unfortunately with IO, it tends to be, we've had 2 goes, we've had a 3rd go, well, we're not getting anywhere, so I want to go just put it in, you know, whatever. And also, if somebody's very badly traumatized in terms of injury burden, and they've got pelvic fracture, they've got femoral fractures, they might have upper limb fractures, you're starting to run out of IO spots that you can use. So that's obviously your issue there, is you need to get proximal to any fractured bone, or not in it at all. So yes, it can be, absolutely.
Amazing. Oh, so yeah, I said that and I knew it would happen. I always do it, so everyone suddenly gets tempted. So Mark Delaghi's asked, is TXA more suited to arterial bleeds than venous, hence better in trauma?
I don't know the answers to that. I don't know is the honest answer. It's not in terms of, you know, it's not I've got a big hole in the vessel and it's bleeding. It's sort of that bleeding surfaces thing is the thought, is how it works. But I don't know. I wouldn't see why it was, but I can't answer that for sure.
Amazing, thank you. And Carla Sinclair's asked, so just to confirm, we can bolus TXA rather than an initial 10-minute infusion.
So if we go back to the top of this, where this is all current literature and it's not that, I would say yes, personally. And I think if you are in a field somewhere and you've just picked someone up from being gored by a bull, that's our typical patient profile here, or someone's been hit by a car and you're there, then absolutely. And again, anecdotally, people who work with critical care paramedics and critical care doctors, they will tell you they've just flushed the cannula with TXA sort of thing. So yes, in my opinion, absolutely.
Amazing. Alan has asked, thank you. Reference to the BASMU protocol for oral route is very useful. Storage in the cold must be stabler. Question.
You'll have to look out for some more literature that comes out of us when it's published by some of our colleagues who've just been deployed, so it might be delayed. But again, this is pre-publication, they told me. But yes, I assume it is stable. It's stable, cold enough stable, rather.
Perfect. Thank you very much. And thank you everyone for your questions as well. I always call you out when we run out of questions, and more always come in, and it works like a charm every single time. So as always, just a big thank you to, see, it's happened again. Callum Dawson has asked, do you think we'll start getting pre-hospital, again with the words I don't know, guys, fibrinogen concentrate?
That's sort of outside my remit of this. The most exciting thing at the moment ongoing is the SWIFT trial, which, if anyone doesn't know, is whole blood given pre-hospitally. It would be lovely to say, yes, blood and blood products are already sexy and they make us feel great when we give them pre-hospitally, and you can come in and go, we've given loads of blood. So far, the data is equivocal. The only stuff that seems to be pretty good is whole blood, which is why now the SWIFT trial is running with several of the air ambulance services in the UK, giving whole blood rather than products in trauma resuscitation. So watch this space. They started recruiting, it's either a year ago or 2 years ago. So in the next couple of years, we might have an answer as to whether or not whole blood is the answer pre-hospitally. But as anyone who has worked with any ambulance service of any kind, sorting that out with blood and transplants. And as someone said, some air ambulances are carrying fibrinogen. At the moment, everyone sort of does what they feel is appropriate based on the evidence that they hold to hand. But it's equivocal. We're really not sure one way or the other. And there's some really good stuff. I don't know if I'm meant to advertise for other things, but Femcast is another podcast service that colleagues that I work with do. They've done a really, really wonderful cover of all the information that came out with the big paper that's name has escaped me now, but looking at giving blood pre-hospitally and what it does. And they also reference a lot of other things. So there's lots of discussion gone around in lots of different places. And if you're looking at the evidence around blood far forward, I would sign into the next trauma care webinar in a couple of weeks' time, but I would have a look at some of those because there's lots of work that is saying different things. But yes, it's logistically possible. It's just difficult getting blood and transplant to work with different services.
Amazing. I'm not sure if this is the same person that's asked this, just because they're both anonymous and it's similar writing style. However, I'm not sure if this is a statement or a question, but make of this as you will. I was always taught IV access and then attach syringe and give over 10 minutes. I've seen in another ambulance service giving it as 1 mil bolus with a couple of mil of flush, then the next 1 mil, still giving over 10 minutes, but just with flushes. When I question this, I can find no evidence if this is good or bad or even makes a difference.
I agree. I don't see why it would make a difference. And I can't understand why you would spread it out. From my perspective, just give all 10 at once. And if you want to give it slowly over 20 seconds, grand. But I think the main thing is all this logistics of setting up something, a pump, putting it there. And, you know, it's all very well and good. You put it on and you give it over 10 minutes, you give a mil, you go back, you check, oh, you've moved. Oh, what have we given anymore? I'll give it a bit more, 20 minutes, 30 minutes down the line. Whereas if you've given it, you know, you've given it, it's in and it's done. And as we've said, there's not a lot of evidence in terms of why it's bad.
Amazing. Last call for questions, guys. We have got one more slight comment / something you can comment on, and this is your last call. One concern has been that TXA is rapidly absorbed out of vascular space. Infusion continues, TXA to be put into places needed. Probably need bolus versus infusion trial.
Potentially, yeah. And there's a bit of this as well in terms of things like if somebody's still bleeding and I give them a big bolus, have I just lost all the benefit from it? I think in terms of the serum, the stuff looking at the serum levels, that's probably not the case, but yeah, it's certainly a concern. And that's also one of the other concerns that was, along with the not confounding things, that was one of the other reasons they kept in this 10-minute infusion thing in the first place in Crash was, if I'm just going to put it into someone and they're just going to bleed it all out again, do I get any benefit? But they still did, even when it was given over 10 minutes, which you'd assume they hadn't stopped bleeding in 10 minutes in every case. So maybe we do need a bolus versus infusion. But as I said, I think the logistical benefit of giving it IM, if we can demonstrate that actually you can get the same therapeutic levels giving it IM, will probably supersede it. And I think that is being pushed quite hard from lots of different ways. So yes, but I think people are probably moving on to different things.
Amazing. Thank you very much, Jake. And third time the charm. Thank you to our sponsors as well, QualSafe. And Alan's just said thanks. Thanks to QualSafe. Do scan the QR code that's on your screen now. They are going to be proudly also orchestrating our first aid stream at our next Yarnfield conference, which is taking place next March as well. Do check them out. They're one of our wonderful sponsors and also good friends of ours. Nigel and Toby are just wonderful, wonderful people, wonderful colleagues to have. Go over, scan the QR code, go over to the website, find out all about the courses and learning materials and learning resources that they have available. And of course, as always, Galen, our long-standing friends and partners over at galen-farm.com. If you are coming to Ireland, come and say hello to them. I believe Bronna, who I've not seen in about 2 years, is going to be there, and I can't wait to see her again. But do check them out by scanning the QR code or going onto the website and find out what they have available for you as clinicians. And that is all we have time for tonight. I say that. We do have some more time, so if anyone does quickly throw something in, I'll quickly throw it at you, Jake. I'm going to stop looking like I belong in a horror movie in a second. Thank you very much, Jake, for your time tonight. Thank you all of you for joining us as well. Wherever you are in the world, I said good morning, good evening, good night. Take care of yourselves. Take care of your loved ones. Jake, thank you very much. This webinar is going to cut off for everyone at the end of this. So thank you for joining us and taking time out of your Thursday evening. It was a really interesting webinar. Good night, everybody. Take care.
Thank you very much, everyone.